Greetings. Let us learn about biopsy forceps. So here is a standard biopsy forceps without the spike, and it allows us to take one specimen at a time. On the other hand, if you use a spiked standard biopsy forceps, it allows us to take two specimens, and the spike allows us to direct the biopsy and also obtain a deeper biopsy. So, compared to the standard cup biopsy forceps, there is a bigger jumbo biopsy forceps that also takes one specimen when there is no spike, but the specimen tends to be bigger. It does not necessarily go deeper, but a bigger volume of specimen. On the other hand, if you add a spiked jumbo biopsy forceps, one would get not only a bigger specimen, but also the spike allows us to take two specimens per pass. So we've learned about standard biopsy forceps with or without the spike, and the jumbo biopsy forceps with and without the spike. The biopsy forceps handling has been presented in another video that you could refer at the end of this session. And biopsy forceps handling is pretty simple. When you open the hand, the biopsy forceps opens, and when you close the hand, the biopsy forceps closes. Open the hand, close the hand, opens and closes the biopsy forceps. It is important to give the biopsy forceps closed when you're handling or handing it over to the endoscopist so that there is no injury from the spike. So let us review the uses of a biopsy forceps. Biopsy forceps during colonoscopy is used to remove polyps, and it is good to remove polyps that are smaller in size, less than 3 millimeters. Millimeter polyps can be completely removed with the biopsy forceps. If you take a jumbo biopsy forceps, you have much bigger volume, and you can be confident that you can remove a small polyp completely. On the other hand, if the polyp is larger than 3 millimeters, biopsy forceps tend to cut them incompletely, and if they have some bleeding, you would not know, despite washing, whether you're able to completely remove the polyp. So polyps larger than 3 millimeters in size should be taken out with the use of a cold snare. In addition to removing small polyps, biopsy forceps are used to sample tissue from different organs, starting with the esophagus, stomach, duodenum, and colon. So let us talk about how do we use a biopsy forceps to sample tissue from the esophagus. And at this point, I would like to talk about technique of using a biopsy forceps in the esophagus. So here, once the biopsy forceps is out of the endoscope, you open the forceps, you pull back the forceps to the end of the scope, you turn the tip of the endoscope to one side, that is approaching the wall, and take a bite with a gentle suction, close the forceps, and pull the forceps. That would get a specimen. Esophageal biopsies in patients with Barrett's, we should follow a standard protocol. So let us talk about Barrett's esophagus biopsies. here is a long segment of Barrett's. You start taking biopsies from the gastroesophageal junction and go all the way up to the squamocolumnar junction. And you typically take 4-quadrant biopsies at 1 centimeter intervals, starting distally and going proximally. So we've learned about how to take Barrett's esophagus, 4-quadrant biopsies at 1 centimeter intervals. And you should ask the endoscopist if he or she would like to put the specimens in separate jars. That is something you need to keep in mind and make sure that you maintain your jar numbers accurately. Typically, when Barrett's biopsies are done, endoscopists will say biopsies at 37 centimeters, 36 centimeters, 35 centimeters, like that, and they should be going into separate jars. It's important for the endoscopy assistant, once the biopsy specimen is put into the jar, he should make a note whether that specimen is of a decent size or not, and he or she should share that information with the endoscopist by saying good piece or a good specimen. Or if it is small, don't say bad piece, but say small piece, maybe we should take one more piece. And you should also communicate with the nurse to make sure the specimens are going into the correct jar, and the nurse is also recording in the electronic medical record so that the jars and the specimens could be checked later on. So now let us go to how do you take gastric biopsies. Gastric biopsies, one should take from the antrum and also from the body, but if you want to see the extent of gastric intestinal metaplasia, that is the area that will be at risk for cancer, it is important to take specimens in a very specified manner. So you take biopsies from the antrum, greater curve, lesser curve, and at least 4 specimens, about 5 centimeters from the pylorus. Put them in a separate jar, and then go to the incisura or angulus, take a couple of biopsies, put them in a separate jar, and go to the lesser curve, take a couple of biopsies, and put them in a separate jar, and then body of the stomach in a separate jar. And if there are any lesions that are obvious, they should go in separate jars. By taking biopsies into the antrum biopsies, incisura biopsies, body of the stomach, lesser curve biopsies, body of the stomach, greater curve biopsies in separate jars, what will happen is when the pathologist says, in addition to inflammation, that is gastritis, commenting on the presence or absence of Helicobacter pylori, they also comment on the presence or absence of intestinal metaplasia. If it is no metaplasia, at least you could tell the patient that their risk for gastric cancer from Helicobacter pylori is extremely rare. On the other hand, if there is intestinal metaplasia limited to the antrum or going to the incisura or extending to the lesser curve of the body or even to the greater curve of the body, depending upon how far from the antrum it extends up into the body of the stomach, you determine whether the intestinal metaplasia is limited or extensive. And that will determine how often patients should undergo repeat endoscopy. So when we are taking biopsies from the stomach, again it's important to comment on the specimen size and also make sure that the specimens go into the right bottle. The endoscopist may take biopsies from the antrum and then come into the body and may take biopsies, maybe starting to take biopsies from the body. It is a good idea for the endoscopy assistant to ask the endoscopist, do you want to put the body biopsies in a separate jar? He may be thinking that he wants to go into the put them in a separate jar, but he may not have remembered to share that with you. So as an endoscopy assistant, you should help the endoscopist as well, so that as a team, you provide the best possible care. Next, let us talk about duodenal biopsies. Duodenal biopsies are typically done to check for celiac disease and also in patients with diarrhea to see if there is any parasitic infestation or if there is any other reason for malabsorption. So the most common reason for taking biopsies from the duodenum is to check for celiac disease. And there is a protocol for doing biopsies for celiac disease. Typically, one should take at least 4 biopsies from the descending duodenum and then also from the bulb at 12 o'clock. And all these biopsies could be placed in one jar. Next, let's talk about colon biopsies for IBD surveillance. Patients with inflammatory bowel disease, especially either Crohn's colitis or ulcerative colitis, if they have had the disease for 8 years or longer, they should undergo surveillance exam to look for cancer. Although the way we are doing surveillance has changed over the years, at one point in time, we used to do a standard set of biopsies starting from the ileum and different sections of the colon, at least every 10 centimeters, 4-quadrant biopsies, about 40 to 50 biopsies per patient. And with the availability of high resolution, high definition endoscopes and the use of either dye spray or electronic chromoendoscopy, people have changed the way they were doing the surveillance biopsies. So if somebody wants to go the traditional route, they should take every 10 centimeters 4 biopsies, and they should be put in separate jars. So this field is rapidly evolving as the endoscope vision is getting better. How about taking a biopsy from a large polyp, especially if the endoscopist decides that he is not going to resect the polyp and wants to send the patient to another endoscopist? And if the polyp doesn't show obvious features of cancer and it looks benign, it is best to take the biopsy from the periphery of the polyp instead of multiple deep biopsies all over the place. If you take it from the periphery, whoever is going to take care of this polyp later on can easily resect the polyp because the tethering will be very minimal. On the other hand, multiple biopsies from all over the polyp, especially with a jumbo biopsy forceps, will cause tethering of the polyp and will limit the ease of resecting a polyp using either EMR or ESD. So, important to keep in mind that when you're taking a biopsy from a large polyp, especially if it looks benign and nothing to suggest cancer, everything looks uniform, take a biopsy from one of the edges. Let us talk about complications of a biopsy forceps. Biopsy forceps is pretty safe. The risks of bleeding and perforation are extremely rare, and they probably happen in somebody who has problems with their platelets or their coagulation. Otherwise, they are extremely rare. I would like to suggest one important point, that is, as we take biopsies from the patient, it is important to make sure that the specimen jars are labeled properly and communicated to the nurse properly. And as you help the endoscopist, also say specimen gone into jar A, good specimen, or jar B, good specimen. If the specimen is not big or adequate size, it's a good idea to share with the endoscopist the piece is small. In terms of how to handle a biopsy forceps and other details, I have included that whole section in a separate video. You could access that, and I'm going to put a link here, and that will take you to that section. Thank you.